Hey, it's me, Jen again, and today I get to introduce you to a new member of the Thyroid RFA physician community. We'll meet Dr. Lindsey VanDyke after this. If you value this content, then please subscribe to this channel because that helps YouTube put this content in front of more people. And that helps more people to learn that they can save their thyroid from surgery through minimally invasive procedures that directly target and shrink thyroid nodules while preserving the thyroid gland itself. Today's guest bears the title of doctor, but has walked many a mile in a patient's shoes. Beginning at a young age, Dr. VanDyke fought her own battles with 3 different kinds of cancer. Her own patient experiences have offered tremendous insight into how to improve her practice of medicine. Earlier this year, she made Thyroid RFA available to her endocrinology patients. Let's get to know Dr. Lindsey VanDyke of Mansfield, Texas. I was just looking over your website. I have to say your website is excellent.
Oh, thank you so much.
You've really got a very clear and concise website with a lot of really great resources on it, and I just thought it was fantastic.
Website is a hub for everything that we do because all of our patient education, all that stuff is centered on there.
Every time I interview a doctor, I always go and read about them just to get to know a little bit more about what we're going to talk about. And I was really amazed at your little bio where you explained how you had cancer in your background and how that kind of played a role in you going into medicine. Could you talk to us about that a little bit?
Oh my God, I've had so much cancer. It's laughable when you're on the other side of it, you know?
Yeah, it's nice that you can laugh about it.
You have to, or you can't get through it. I started that whole process when I was 11, and I had a Wilms tumor, which is the most common pediatric kidney cancer. But that being said, there's only about 500 cases a year. And I actually had that twice. Then I got thyroid cancer, and that was a direct result of the radiation therapy they had given to me for the other cancer.
Mhm.
And so, that's a neat little detail that when you are in the throes of an advanced cancer diagnosis, everybody is laser focused on getting treated, not dying. The discussion about long-term consequences does not come up. Or at least it didn't at that time. Here I was in my senior year of college, and of all people, my dentist found this thyroid nodule. And it was funny because it wasn't even my normal dentist. I was at school and I needed to see a dentist, and he does a full head and neck exam. And he goes, "Oh, there's a little something to feel there. You should see your doctor about it. It's usually nothing." So I go see the doctor, and they do the ultrasound, they do the biopsy, they do all the stuff. Boom, cancer. And so I went back to the dentist and I go, never in my life has any dentist ever done a head and neck exam. And he goes, he kind of draws himself up. That's standard dental training. If they're not doing it, they're just being lazy. Never in my life since then has anyone done a head and neck exam at the dentist.
Wow. But what an amazing thing that he did that and found that for you. I mean, it could have been there for years longer before you even knew that it was there.
It probably would have been there for years longer. And so, I mean, I got it treated and it was so small. It was less than a centimeter in size. And by modern standards, we don't mess with nodules that are smaller than 1 centimeter unless there's a very, very compelling reason to do so. That was an extremely early detection. I was able to resolve it. I've not had any problems since then with thyroid, and I just take my pills and I do fine. And then I got more cancer. I got breast cancer a couple of years ago. Again, they think this is related to that chest radiation I had as a kid. When I got into young adult survivorship follow-up, that they said, well, what we find is women who were treated between the ages of like 9 and 13 with chest radiation and this threshold amount of radiation, that your risk of breast cancer is about as high as someone who has a BRCA gene. Yeah, so I had really close follow-up for years, mammograms every year, and every time I went in, they would look at me like, why are you here? You're too young, you shouldn't even be here. I skipped it 1 year, and then the next year, I had stage 3A. If they're telling you to have your mammos, don't skip them, even if they're giving you the right eye while you're doing it.
Wow. So you are a 3-time cancer survivor.
Yeah, 4 episodes, 3 different types.
Wow. Man, you're a strong woman. That's a very interesting backstory for a doctor to tell because I think sometimes patients have a hard time remembering that their doctors are people too. And to hear that you've been the patient, they can identify with you, I think, in a different way than otherwise.
And it's funny, you're right. Especially if I got a patient who needs to have surgery for thyroid cancer, I could say, hey, that's what it looks like later.
Yeah.
Okay. And that is reassuring because most people still think that this is this big smile that they cut into you, which is so rare nowadays. I can say, hey, I had the radioactive iodine. I take the levothyroxine. I've done this now for 20 years. I'm fine. My life is normal. Everything is okay. But your point is well taken because I had the opposite experience when I was applying to medical school. And it was a very important part of how I identified myself as an applicant. I've been on that side of the patient bed and I know what that is like. And so to flip to the other side of the patient bed and use that knowledge to enhance how I approach care was so valuable. And I thought that was such a rare thing to have that extra expertise. It was astonishing to me how I was treated with such suspicion. And they would say to me in these interviews, so you've been sick before, like, why does that make you a better candidate? Why does that give you the right to be the doctor? That was a common thing. I interviewed all across the country. Georgetown said that to me. University of Washington said that to me. Oregon Health Sciences University said that to me. I ended up applying to some osteopathic schools. There was a very, very different culture there. That holistic approach that you approach a patient as an entire person, not a subset of symptoms or a diagnosis code or whatever. And that was the very first time that I would be in an interview setting and I would talk about why these experiences were simultaneously horrifying and enriching. They would say, oh yeah, tell me more about that. And so that ended up being just a very, very natural fit for me.
That is amazing. I wish I had access to more DOs around where we live here. I had one conversation a few years ago with a DO, and it was just a very different conversation than I would have in an MD's office. And so for patients who don't really understand the difference, could you maybe explain a little bit about that?
So America is unique that we have 2 separate types of fully licensed physician surgeons. They both can prescribe, they both can do surgery, they both can deliver babies, they do it all. They both have fully independent practice rights. They used to be far more different in the past because they developed almost simultaneously, roughly mid 1800s. Like institutions had true medical schools. So the first DO school was started in the mid 1800s, and I'm trying to remember exactly when the first MD school was started, but it was approximately the same time frame. Now, back then, there was no pharmacology. We didn't even know what aspirin was. We had no Tylenol. We barely knew what morphine was. We knew kind of what a few things were. They were not pure. They were not regulated. They were not safe. And so if you called the doctor for whatever problem you had, the odds were kind of 50-50 about whether or not you would get better or you would die. And whether your death would be related to the disease or the treatment. Dr. Andrew Taylor Still was the godfather of osteopathic medicine, and he said, this is garbage, there's got to be a better way. And he developed this concept that structure and function are intimately and infinitely interrelated with one another. He developed his entire branch of medicine that was based on manipulation of the musculoskeletal system. Now, as time went on and Dr. Still died and pharmacology became its own discipline, there became a board of pharmacy and we began to understand biochemistry and we understood how to purify things and target things. Medication became necessary. Gradually, the osteopathic schools kept their musculoskeletal training, but began to integrate all of the other things that we associate with modern medicine. Now, I would argue very strongly that there's no measurable difference between the curriculum at any given MD school versus a DO school, aside from hands-on musculoskeletal manipulation training that we all get. And now, just to blur the lines even more, the residency training programs in the United States, which used to be distinct, there were MD programs and there were DO programs, they are all merged now.
Still a very interesting background discussion about, the history of all that. And then you decided to become an endocrinologist. So where did that journey start?
Well, much like the thug life, endo chose me. You think when you go to med school, you think, oh, I'm going to go and do this. I'm going to do this thing. This is the thing I like. But it turns out that the curriculum is designed to expose you to everything. And you end up being surprised, usually, at what you thought you loved, you end up hating, because administrative tasks, pay isn't good enough, you don't like the call hours or something, then you get exposed to things that you never even imagined. I had like a basic understanding of what an endocrinologist was because I had had my thyroid cancer at that point, but I thought it was too hard. But I went to residency kind of thinking, well, I'll be internal medicine, I'll do hospitalist work or something. And again, over the course of that 3-year training program, there are a number of things that I just developed a very good skill set. Somehow I became the go-to for endocrine problems, for diabetes management in the hospital. That was my bailiwick. I found myself moving to New Mexico from Long Beach, California. I had never considered setting foot in New Mexico until I applied to fellowship. I was completely captivated by the whole thing. And yet here I am. I find myself now, again, by unforeseen circumstances, new things that I never imagined I would run into. Here I am in Texas doing endocrinology.
I want to talk some about your clinic. As I said, I really love your website, how you've got all the patient education just very clearly laid out. And of course, RFA, which is the big thing we're going to talk about today. Let's talk about what brought that to your attention and what made you decide to bring that on in your practice.
I think I got some random email through some professional association I'm a member of that had said there was a lecture, a training lecture to attend. And I thought, well, that's interesting. And I like procedures. I like to use my hands. And so I signed up for that. I thought there's probably no way that I could pull this off myself. I probably need like an ENT surgeon to team up with or something. And it became clear, even though that course was taught by ENTs, this was a slam dunk for people who have benign obstructive nodules, cosmetically annoying nodules, hyperactive nodules that are in some way or another opposed or unable to have the radioactive iodine treatment. After speaking with Dr. Kathleen Hands more about this, that why do we take such a primitive, almost barbaric approach to thyroid nodule management by taking the whole thing out or taking half of it out? If there's not cancer there and we don't have to do extensive staging of disease, what are we doing there? And then they're stuck on the pill for their whole life, and don't forget to take it because then your thyroid goes low and that can be a problem. So it really seemed like a natural addition to my practice. And technically speaking, procedurally, it's no more complicated than doing the biopsies that we do anyway. And so very quickly I figured out that I don't need an ENT surgeon to be part of this. I can do this. So we did.
We talked about previously, you did some training with Dr. Hands.
Yeah, she trained me how to do it.
Yeah, I love Dr. Hands. We've done a couple of interviews and I love her passion for this, how important it is to her to help patients preserve their thyroid.
And it's funny, I just went to the ACE conference in San Antonio and I talked with her and she lectured about RFA, but she was saying that there's only 70 practitioners who provide this in the United States right now. That is astonishing to me. I believe it'll become the standard of care.
We put together a spreadsheet back in, I want to say in March, because we had a list going in our Facebook group, and it was not in any organized fashion whatsoever. It was truly just, hey, I heard of another doctor, add them to the bottom of the list. The list was long enough that I thought, you know what, let's take this off and put it into a spreadsheet and put them in alphabetical order by state. Mm-hmm. And when I did that, I came to the realization we had 68 doctors. I just added today you and one other in Texas, so now we have 70.
Yeah.
Which is amazing and sad at the same time.
I know. Yeah. As a young physician, as someone who's starting a practice from scratch and everything, which is scary and expensive and all of that, that when you're staring down the barrel of whether to take on radiofrequency ablation, you are having to figure out how to get that generator. That's a very scary expense to take on. For a field that we normally just sit around and look at labs, you know, we don't have a lot of equipment that we have or deal with. But it's very clear, I mean, at the time that I decided to pull the trigger, no one else in this metroplex in the Dallas area was doing it. Now there's someone in Southlake, and there's, I believe, Baylor in Dallas is doing it, or maybe it's UT Southwestern, and then there's me.
I know from the patient load that we have in our Facebook group that there are a lot of patients that are in Texas or in Oklahoma who would travel to Texas. From the 2,600 patients that we have, I hear a lot of people saying, you know, it is just too important to me to lose my thyroid over these benign nodules. More recently, a lot of patients saying, I want to have my thyroid cancer treated. And I know that not everyone's doing that yet, but I think that's coming. What do you think about that?
Yes, I agree. I think, and she touched on this too at that lecture, that the data about some of these micropapillary thyroid cancers and some of the subtypes of thyroid cancers, we are always kind of arguing with one another, do we even still call this cancer? That data is forthcoming. We are anticipating that it will be positive.
That's very exciting. I think that when we can stop, as you said, going along with this barbaric method and really just addressing these little blobs of tissue that don't need to be there in a very direct, targeted way, that down the road, we're going to see a lot less, in my opinion, chronic health conditions that are associated with improper thyroid function or low thyroid. Or when you were telling your story a moment ago about how, you know, you had thyroid cancer and you take thyroid medication and that you feel fine, that is amazing. I'm thrilled that that is the case for you, because I've heard so many stories of people saying, I feel like trash. You know, I can't get my meds right. I don't do well on any of the meds that are available. You know, that was a big reason for me. I didn't want to have my thyroid nodule removed because I don't tolerate pretty much any medication I take. And it was a huge concern because I thought, I'm going to be on this for the rest of my life. And I'm not the only one who's concerned about that. That's a big part of what makes our group so interesting is seeing how many other people are out there with these same concerns or health conditions that, you know, cause them to be more interested in an option like RFA. I would not be surprised if you start seeing patients coming from Oklahoma and the DFW area. And even I was talking with someone yesterday from West Texas. There's not, to my knowledge, anyone in West Texas. So this is exciting that you're doing this now. It's just another tool in your arsenal.
Yeah, and one thing that's so clear about endocrinology is, and in medicine as it advances in general, individualization of care is paramount. And so this is why this job cannot be done by robots. This is not algorithmic medicine. You have to look at all of the subtle nuances in a patient, everything from other diagnoses, other medications, mobility, finances, educational experience, motivation for that matter, that will affect what you choose to do for that patient and what will be the most effective thing. And that's why not everyone should have surgery. And for that matter, not everyone should have RFA.
I love your whole perspective. Very cool, very refreshing. The coolest thing is that now, because of our own personal experiences, we're getting to do that. You're getting to help patients be able to keep their thyroid, and I'm helping to point them towards the doctors that do that. So it's really something that I can't speak for you, but I personally find it very fulfilling, and I'm sure you too.
Oh yes, we ardently stamp out metabolic disease every day of
Mhm.
all kinds in our clinic. And it's, my nurse, who is my right hand, she considers her work here, that is her ministry. That is how devoted she is to what she does. I hope she never leaves me, because I don't imagine I would ever find anybody as dedicated and as good as she is.
I've certainly enjoyed this. I would love to point patients in your direction. I hope that you see plenty. And would you have anything else you'd like to just tell us about your practice or about you?
Pertaining to having this procedure done, having had fine needle aspirations done to me before, my experience was horrifying. It
Mm.
was just so awful. I take that very personally. We've structured our clinic that nobody is a means to an end. And so from the moment patients walk in the door, everything they see, hear, smell is designed to activate and engage them. We have a wonderfully warm and bright facility. We partner with local arts communities, so we're supporting local artists in our lobby. When someone is having a procedure done, there's music going in the room. They get their lavender aromatherapy eye pillow. I am very, very careful about that nerve block, because I could not stand not having a nerve block done when they did my biopsy. And I'm very, very careful about the amount of pressure I apply with that ultrasound probe, because when I was having it done to me, you're anxious, you're thinking you might have cancer, and then someone's got this thing on your throat, it's like they're trying to choke you, and how are you supposed to deal with that? And I hated it, and I don't want people to have to feel that way. I want that phenomenon to have died with that time back in 2002 when that was done to me.
Wow, that is amazing. I love that. You've got me wishing I was in Texas. Unfortunately, I'm over here in Alabama, and we just have one physician here who just is about to start RFA. But that's better than none. 2019, when I started down this road, there were none here and none anywhere near here. So I'm very thankful that this procedure is growing in popularity and prevalence, and I only hope that one day it'll be available at every endocrinologist and ENT's office. And it'll be no big deal to just go in and get it treated and then go about your day and keep your thyroid.
Keep your God-given gland.
Absolutely. Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.